Hi, I'm Stephanie Shelton, and this is episode 45 of Conversations on Health, How We Get There. Now, I think most of us know that AI is rapidly changing the meaning of that now rather old-fashioned sounding phrase, I'm going to the doctors. If you go for a scan of some kind, AI is now involved. Same with making appointments or the patient portals that almost all of us use now, willingly or not. If the AI is well integrated and it works well, it saves time. If it isn't, and that's too often the case at the moment, we hate it. But the speed that some version of an AI is moving into all aspects of American healthcare is accelerating, and it appears there's no stopping it. And indeed, if AI is improving your healthcare, why would you want to stop it? So, is it? In episode 43, we learned what a well-integrated AI can do in an advanced, well-organized healthcare system, as they have in Israel. And Israel is already far ahead of the U.S. in using AI to improve direct patient care. In our own more fragmented, more competitive, mostly for-profit system, the deployment is primarily in the largest hospital, imaging, and doctor groups, and in the big insurance companies. So, in this episode, we're talking to someone who's at the helm of AI rollout at Optum, the huge health services and technology arm of United Health. Dr. Racquel Moore is Vice President of EHR Strategy, Governance, and Special Projects at Optum. EHR, by the way, which I had to look up too, stands for Electronic Health Record. It's broadly replaced most paper records. At Optum, Dr. Moore leads enterprise, AI, and digital strategy across a large multi-platform healthcare network. She has over 20 years of experience spanning clinical care, operations, and health technology. And she focuses on scaling AI in a way that improves provider efficacy in big and small ways, so that ultimately both providers and patients should benefit. As always in these informal conversations, we used first names. Racquel, thank you so much for coming on the podcast. This should be so useful for our viewers and our listeners.
Wonderful. Thanks for having me.
So if you could, rather than me try to explain what you do, could you just very briefly tell me what your job is and what it entails?
So my job entails connecting clinical workflows to technology to make it a seamless experience for our patients and our clinicians and to make us more effective and efficient. That's the easiest summary. I can dive in a little bit more.
No, it sounds good to me. You're more on the technical side in that sense.
Correct. However, the technology that I work with is to connect the clinical space. So the patient experience, the clinician workflows end-to-end, and the supporting roles that supports your end-to-end visit with a patient.
Who benefits most from what you do? Would it be the people who work with the technology, the clinicians, the insurance companies, whatever, all those people up there that we as patients don't immediately deal with? Or would it be patients or would it be doctors?
So I think of it like this. In all the work we do, the patient's at the center, and everything else is peripheral, benefiting the patients. So it's the clinicians. How can we improve their workflow to benefit the patients? It's the patients. How can we make their experience more seamless, easier? It's to your interoperability. How can we integrate the medical records and the chart to bring all the information to one place so providers can care for patients? So everything is with the patient at the center and making patients healthier and making their experience better.
Where are we now in all of this with AI, which is really what this podcast is about? I told you, and our listeners and viewers know because it's in the show notes, and they also have the podcast to listen to and watch, that we basically looked at the Israeli system, a relatively small country with a very advanced technical, from a standpoint of technical system. And one of the so-called insurance companies that they work with, it's universal health care, but they call them insurance companies, but it's a completely integrated system, hospital, everything. They have been they were ready for AI because they were digital way before any of us were digital in the sense of patient records and all of that. And they are way ahead of us in the sense of the way AI is being used. So, where are we in the United States in terms of your systems that you work with and then the big picture?
Yeah. And I'll take a step back as you asked broadly, where are we in the United States?
Yeah.
So I've been in the healthcare industry for over 20 years. I started on the front lines. I'm a mammographer, sonographer, so I scan babies. If you have a clot in your leg, that was my job 20 something years ago, right? Before AI itself was even a major focus. I've led medical offices, supported operational workflows, and I have a deep sense of understanding of the challenges that our clinicians and frontline users face as we try to deliver quality care. As I've transitioned into leadership roles and I've worked at the intersection between clinical workflows and technology, I mean, a big part of my work involves partnering with clinical teams and understanding how we can use the electronic medical record better to align with how the clinicians deliver real world care. Over time, that has naturally evolved into governance, digital transformation, to what you've mentioned, and now AI. So we've been using digital tools to enable clinicians to be more efficient, deliver care, quality care. But now that we have AI at that intersection, we're looking at those abrasion points, the frictions in the workflows. So, for example, a patient being able to quickly schedule or reschedule an appointment without waiting on hold to speak to someone. Mm. How can that patient send a message to say, I'm here, I'm going to check in on my phone, right? Instead of waiting in a line to check in at registration. We're using AI to respond to patient messages. If you email your doctor and say, I'm not feeling well today, or can you fill my prescription? The AI will draft a message. There's all assisted technology. It will leave the message queued up for the clinicians and have that message ready to go. Clinicians are now saving 30 seconds because they're not starting from baseline responding to the patient.
Yeah.
It gives, that's how we're leveraging AI. So it's part of the digital transformation work that we're doing in the United States across many healthcare organizations, but more so, how can we infuse AI as assisted technologies, human in the loop, but to help us be more efficient across all our workflows.
And I think that's what in the end, from a patient standpoint, but also I think from a clinician standpoint, the clinician wants more time to spend with the patient or thinking about how do I diagnose what the patient is showing me or giving me. And the patient desperately just really wants to talk to a human doctor or clinician and say, what's wrong? Fix it.
Yeah, absolutely. Do you remember 5 years ago when you went to the doctor and you sat in front of them and they were behind their computer typing, trying to search? I remember doctors asking me, well, did you have this X-ray? When did you have your MRI done? I mean, who remembers that? And thinking, maybe you're guessing, right?
Yeah, right.
Because, they have X number of patients per day. They've done their research. They're fishing through the chart. They're looking and getting acclimating, especially for a new patient. If the provider is seeing that patient for the first time, they have to understand your history, learn your social needs, not only your medical needs, and put the big picture together. Now imagine having a AI capability that can summarize that chart in 10 to 15 seconds. versus providers spending time, what we call pajama time. That's the time outside of work, the time you should be in your pajamas. We
Right.
call it, they're spending that time reviewing your chart, reviewing my chart, so they can deliver care. And during that visit, they are still reviewing the chart to ensure that they're diagnosing you appropriately, having those dialogues. But now we can queue up a summary so that they can talk just like we're talking. They can look at you and discuss with you and have that summary in front of them. It's like prepping for a presentation or prepping for an interview, right? You do your homework, you have your printout, you're ready to go. Providers now have that at their fingertips.
How long does it take you to roll out some kind of a change that involves AI to this type of thing you're talking about?
It does take a while, and I will say a while because we're doing it responsibly. So we have AI governance in place, and what we do
What do you
from
mean
end
by
to end.
what do you mean by AI governance? I hear
Yeah,
that a lot. What is
yes, that's a great question. So with governance, there's a multidisciplinary team that evaluates the tool, prioritizes the tool, designs, tests, reviews the results, and determine, is this tool valuable? How will this tool enable our clinicians provide better experience, make our patients' lives healthier? Does this tool work? And what is the performance of the tool? Is the tool hallucinating? Does the tool show bias and fairness? That's the type of evaluation that's done with governance. So governance ensures that we're responsibly evaluating tools, we're responsibly rolling them out. The tool will provide adequate value, and there's that multidisciplinary team of legal, compliance, data scientists, clinical informaticists, clinicians, operations who are end to end. When we look at a tool, we ensure that the value is there and the tool will perform as expected. And we have guardrails in place. So when you think about governance, you think about guardrails.
yes.
Are we able to monitor it? How will we monitor it? What is our tolerance levels? What change will we make if there is an hallucination found? And how do we get stakeholders or the end users who are using the tool to report feedback to us? That is in its essence governance.
That sounds comforting to someone who doesn't know a great deal about
Yeah.
the technology. So, getting back to that original question that I interrupted, how long does it take you, given what you just said to us, to actually get it something new working in the system?
It can be anywhere from 6 to 9 months.
Well, really?
Yes, from prioritization to design to testing, change management. We want to ensure that the end users understand the tool. These tools are assisted technology. We train, we have office hours, lunch and learns. And when we roll these tools out, we don't turn it on. I support today a large number of providers, thousands of providers in the tens of thousands. So when we roll out these tools, we do what we call an alpha pilot, which will roll it out to maybe 100 or less, depending on the tool, end users. And then we test after 30 days and we get feedback from these users. Is it working well? What should we change?
Mhm.
Is it ready for prime time, essentially? And then we roll it out to what we call beta users, which we add maybe a couple more hundred users. And we do the same repetitive exercise. Is it working well? We pull data. We review these summaries. For example, I mentioned the summary tool that will summarize the medical record. We review, are the summaries accurate? And if the tolerance levels are met and we see no clinical risk, then we'll roll it out broadly. And month over month, we continue to monitor the tools.
I can see in the not too distant future, at the rate I hear some of the technology people talking about how quickly AI is learning for the next iteration, that by the time you finished rolling out, you've got changes to make.
Absolutely. But it's benefit and risk, right? And for our patients, we would rather be responsible and roll them out well, understanding that technology is moving fast, and that's fair. However, we are doing our due diligence to ensure that the tools we're using are meeting the needs of our customers.
So right now you're actually rolling out something new that is going to be helpful, particularly, I think, to the overworked doctors who are like burning out like crazy and saying, I don't want to do this anymore. Like you said, the pajama time, everything. I have no life. Tell
Yeah.
us about it.
Yeah. Um, what we heard, I had a message come through from one of the providers, and all it said was wow with an exclamation point. One of my colleagues said she received the message, and a provider said, this is a game changer. Another provider reached out, and it was within the first week we rolled out the first alpha pilot, which is that small group. And he said, Raquel, I had a patient that was discharged from the hospital. The discharge summary was not available, and the patient was to be seen the next day.
Mm.
He said, typically, I would have to piece the information together, call the hospital, get the discharge summary. He said, I jumped into what something's called Care Everywhere, where you can view outside records. And he said, I used the tool, and it was not even 8 seconds. I had a summary of the discharge notes, and it was one of the best summaries I've ever seen.
Wow.
He said, what can I do to help get this up to my fellow colleagues? Because at that point, we only had a small group using the tool. And since we've been live probably about 6 weeks or so, I've seen almost 400,000 summaries generated. And the feedback from the providers have been overwhelming. It's just, you can have a patient who has a medical record years back with multiple complexities, and providers were sitting there reading the notes, reading their fellow specialty doctors' notes. Now they can type in the condition, they can say hypertension, and the AI tool will present them a summary, and it will give them a link to click at the end of each sentence that they can jump back into the actual note that the summary was pulled from.
Wow.
So it gives them a
Really?
reference. So it's not just a summary that, you may have to wonder, well, where did the summary come from? Is it accurate? You can click the link at the end of every sentence, and it'll jump you back to exactly where in the chart it was pulled from.
It's really interesting because essentially, I, as a journalist, have to research every story, every podcast, every interview I do. So instead of going to Google in the old way, I use Gemini, which is Google's AI, and
Yes.
I put in, tell me about blah, blah, blah. And I get a summary that's written that way with clickable links in it. And then with all the places that the material is drawn from that are the most important right there, so I can go directly to the source if I want to.
Wonderful. I mean, you're just like everyday use. I use it the same. I mean, I did my doctoral degree 5 years ago, and I remember the days of just digging through research articles and multiple websites to find the perfect article,
Right.
right? And now you're right. You can use Claude, you can use Gemini, and patients are using those tools as well. So we're trying to equip patients with the right tools in the right place, so they're not going outside to search for their care or try to understand their condition or a lab. Imagine having that embedded in the electronic record itself, or presenting that to them in a MyChart version that is understandable, readable, something they can consume well by using AI.
And I'm seeing that my doctor group is in my chart. When we should tell people that that's that epic my chart, which is growing like topsy, I think, in terms of because we've used it for years here. But when I get the results of my annual blood test, let's say, it used to just say what they are and what the values are, so I would know what the center was. Now on the side, there's a link to Clink. What are we talking about here? What is this blood test you're looking at? So you can literally get a small piece of medical education right in your own computer.
Exactly. And that's in all the portals. My chart is one piece of it, but any patient portal, you can embed the AI capability. And instead of a patient having to search through Google Gemini or just regular Google or, or Safari and figure out what does this lab mean? What does this level mean? Exactly. It's
Yeah.
presented there for the patient, but responsibly in a controlled setting.
Yes, right. Okay, so um, we're we're talking about when you talk about providers and you're rolling out, how many are we talking about? Because your Optum is a very large company, I think, in the medical business, quote
Yeah.
unquote.
Yeah.
What are we
I
talking
sup-
about?
well, I directly support over 7,000 providers and clinical users that could range over 15,000. Indirectly, it's in the tens of thousands because we have multiple providers in our employed space as well otherwise. So, yeah, it's a large group. And when we start, we do those pilots across different states, across different markets because the population is different in each market. The
Right.
needs are different. You have rural health patients. There's just different needs. You have risk-based lives. You have fee-for-service. So we try to, our goal is to ensure that these tools can meet the needs, no matter the services offered, no matter the needs of the market. And when we pilot, that's why we have that multidisciplinary group because everyone gets to weigh in and we are able to tailor and configure these capabilities to meet individual needs of the markets.
You say you use that Epic My Chart is like the largest of the portals. What other portals do you work with?
We have a handful of strategic vendor partners from an electronic medical record perspective. And, these portals have various names. Epic may call theirs My Chart, but at the end of the day, it's just patient portal,
Mm.
right? So we work any patient portal, they all pretty much present the same information. To your point, present the patient's labs. When they have an imaging study done, they get the results. They can send a message to their provider. And within each portal across our very large landscape, we work with the individual systems, each electronic medical record to implement capabilities that will work well with that system.
Do you see advances that I mean, to me, because I have a long history with my doctor and my chart, actually two of my doctors, totally unrelated to each other, both used it, and so there was some interchangeability there, but very little. You switched from one group essentially to another.
Yes.
But do you see a situation where these portals are going to be able to talk to each other if you're not in the Epic group? Let's say that's another, I don't know any of the other portals, but let's say that they're if you're on Medicare, for example, you can go outside any group you want. You can go to any doctor you want. So let's say you have a doctor on in one portal, a hospital in another, and maybe some specialist or a podiatrist completely unrelated to anything else in a third. It's their right now they don't talk to each other. You
Well,
can ask them to send something to to another doctor, but it wouldn't be what I call talking to each other. It's a process that takes a while and doesn't always work. And I just tried it and I know it doesn't always work.
yeah, and I think that's fair. I think that's a frustration that, and it's something that every patient have experienced. To your point, you have experienced it, I as well. And interoperability across the healthcare industry has been a major focus. I know there's been a lot of meaningful work done through exchanges with qualified health information networks called QHINs, and broader data sharing frameworks, connectivity efforts across healthcare systems and EHR platforms. Where my work is focused is on how AI can improve the experience and the information that's available. So helping clinicians navigate maybe those PDFs that are sent from your provider A to provider B. You remember you mentioned two separate systems.
Mm.
How can we have AI read that PDF and present that information in a summary to reduce that
Right,
administrative burden? I think
right.
there's a lot of good work happening in the interoperability space, but we still have some hurdles to go through.
In the beginning to all of this digitizing, um, now I live in the New York City area, where if there's going to be a level of sophistication, this is where you're going to find it among providers. They didn't want it. They didn't want to switch over. They didn't want to digitize their folders full of their, their patient information. They didn't want the hospitals to be able to talk to them directly. I don't know. Somehow it was their individuality was being threatened as providers, and then the groups got bigger and bigger of doctors, and they had to start doing something. But there was a lot more resistance, I think, and this is. I'm looking at this as both a patient as and a healthcare reporter in the medical field than you would find in many other fields to just moving forward.
Yeah. Yeah, I agree. My mom is a healthcare worker. She's been an RN most of her life, and she worked on paper charts. And when they converted to electronic medical records, she resigned and she retired actually. And I said, "Mom, you can do it." She said, "No, no, this is where it ends for me. I've had 50 years as a nurse and a midwife, and I'm happy with it." Similarly, I saw my PCP, my primary care provider, and I said, "Hey, aren't you going to turn on a Scribe so you can just listen to the conversation? Because that's another AI tool that a lot of providers are super excited about. They get to sit with their patient, they ask for permission. Is it okay if I use this tool to transcribe and listen to our conversation?" They are able to look face to face with the patient. And he said, "No, no, I'm not there yet. I like taking my notes and I like typing." And I said, someone in technology, I said, was as a patient, I want you to use it. He said, "Oh, you might have to find another doctor. I'm not there yet." And I mean, we see that across the various groups of providers. You may have some that says, "What next, Racquel? Speed it up. Let's get this in. This is great." And then you may have another subset that's a little more hesitant, saying, "Well, I like doing it this way. This way has worked for me for 20 years." That's the change management piece that you asked about earlier in the session. And I think it's for those providers, what I find to be very useful and successful is involving them in the process.
Mm.
If they're a part of it, you get more buy-in. They can help with direction. They can help with customization. And then they're the ones that end up helping you champion these tools. And you're right. I mean, healthcare, we have to get to a digital place, right? There's mandates in various places, various regulatory bodies that says, we may need to, organizations must move from paper charts to electronic medical records, conversations that I'll leave for those experts, policy
Mhm.
experts and others to speak to. But I know those mandates are there. And to your point, that organization eventually had to shift.
Hmm.
But it's, how do you get people who are hesitant, maybe are unsure, you bring them, you fold them in. That's always been something that's worked very well for me. If they're a part of it, you can get their buy-in.
I've always thought of doctors, particularly and medical personnel. They're very controlling of their own space, their own patients, their own office. And it's far more so than those of us who just work in corporate, and I spent most of my life working in corporate America, would be, because in corporate America, your boss tells you to do something in the beginning and you say, "Yeah, sure, anything." And
Yeah.
you get, you learn that way. You get in the
Yes.
habit. You can't sit there. If I work as I did once for NBC, they're not going to tolerate anybody sitting there and saying, "Well, I don't really like this." taking my agency away or whatever. No, it's, you do it or you get fired.
Um, and I think in some ways that top-down approach works, but I think in other ways, that's why governance is important because everyone has a voice and it's not only top down, but it's bottom up. Because sometimes if you get to the root of the why,
Mm,
and those providers tell you, well, here's why I'm hesitant. If you take the time to understand the why, you most times, most often than not, trust is built and once you can explain the value, show the benefit, and show how it will improve their patient care, to your point, they're protective of their space. And
yeah,
their space is, I went to school to take care of patients, right? This is what they spend 8, 12 years studying. They want to care for their patients. They want to see their patients healthy. So if you can tell the story of, hey, listen, this is what the data shows. Here's what your colleague is seeing. Here's how it has benefited the patient. Then yes. Change management is hard. We have governance. We go through 3, 4 months of testing and showing performance, and then we get to the market, and the market may say, "Hey, we have these priorities. Do we have to do it right now?" And I'll show, there's another tool that I'm actively rolling out. And the first site that's gone live, we've seen over 200% more recommendations. And with this tool, if you have an imaging study, for example, and the doctor accidentally finds something, so we call it an incidental finding. So you
hmm,
went for a CT of your chest, but they saw a tiny nodule or a little lump
right.
somewhere,
Yeah.
right? They'll put it in their notes in the report, which the patient will get through their patient portal. And this AI tool, in current state, many organizations, not only does the provider review the report, but there's a group of administrative resources who reviews the chart as well, and they call back the patient to say, "Hey, we saw this little thing here. Come back in for this additional imaging, or go back and see your provider. We're scheduling you." This tool now reads all the reports and pulls it into a work queue. So you can see if the radiologist had read 1,000 reports, it'll show you all the reports, maybe 50 of them that had an incidental imaging,
Wow.
right in one spot. We've seen over 200% of recommendations, follow-up orders, and we're catching cancers earlier. We have patients going through cancer treatment sooner. And it's an assistive technology. It's assisting the docs, it's assisting the administrative users. But when you show numbers and you show, hey, this patient was able to be seen faster than this patient because the tool was able to read this in 2 seconds.
Hmm. That sounds really good.
Yeah. Yes. So that's, I would say it's not an easy answer. There's no trick. There's no luck. It's partnership, it's collaboration, and it's showing the value, building trust, and ensuring that the users are part of the process.
It's very interesting because one of my shows is going to be this summer what it's like to be a medical student in another country.
Right.
And I was talking to the guy that I'm going to be interviewing, and he's rattling off about he's going into radiology, rattling off about AI, and it was just part of the course. I mean, there was nothing unusual to him about it. It was just I'm learning about anatomy. I'm learning about using AI, specifically in the material that I'm learning about. Yeah, it's great, and let's move
Yeah.
on. So there is going to be at some point this change of attitude as the younger doctors move up and are
Yeah.
used to using AI and everything else in their lives. They grew up with it in a sense.
Yeah. Yeah. I mean, even for us, to your point, just searching for articles, even myself, just reviewing schools for my senior, I just drop the schools in and say, hey, provide me a table with all the requirements for each school. And
Yeah.
now I have it in one place. So you're right. Providers are saying that, hospital A has X number of features live, and this was great. And this is why I used it. And this is how it saved me on pajama time. It's It's and it's moving fast. It's moving very fast, but we have to do due diligence at the same time. As you can imagine, I know for myself, I have used Copilot, I have used other forms of ChatGPT, just OpenAI, and it's provided me a response. And I said, no, that's not what I wanted, right? That's
Mm-hmm.
not what I was looking for. And you may have to prompt it a couple times to get what you need. And that's why, within the tools that we're using, there's always a human in the loop. It's all assistive technology. There's nothing that the AI tool is doing on its own that's providing any care. It's let's queue something up, let's have it ready, let's have it at the forefront so we save the provider time so they can spend that time face to face with their patients.
Let me move on to the one area that I think bothers a great many of us who cover healthcare in general. What about the impact now of AI on racial disparities, on income differences, on educational differences? The patients I'm talking about. Um, an AI is trained on what is available already, what is in the system. It's not creating new material. And then it's taking from there, and the next AI will build on what it knows, and so on and so on. If that information is already not correct, because the way we find out about things is not correct, the questions we ask may not be correct. I mean, it's like taking a poll. You've got to ask the right questions. The poll's only as good as the questions and the way they're acted, the way they're asked and what they're directed at. So here you have this growing AI system outside of yourself, building, building, building on each other. Is there going to be a way to correct for all this information that we have now that is really not correct, and maybe one of the reasons why you don't get the kind of compliance from certain groups of people that we're really looking for?
Let me see if I can. Let me break that down. So, and I'll say this within governance and within our multidisciplinary council, when we review and do functional performance testing on any AI feature, part of that analysis includes bias and fairness testing across demographics, right? The information is, to your point, is pulled directly from the electronic medical record. That record is updated and validated by patients themselves. When you go to check in for an appointment, your information is there. It asks, is this all accurate? Right? We take that information directly from the medical record and we analyze it to ensure that across gender, across certain race, across certain age, we're not seeing disparities or seeing lack of performance or increased bias from one to the next. I will say, in reference to its continues to build in the electronic medical record, I'm not saying there potentially couldn't be any gaps. However, for the work that I do in my space, we're not looking at a broad, at a open space. We're confined within the information in electronic medical record. So if the patient provides that information and that's what we have, yes, the tool will use the information that's in the chart. But like I said, year over year, we have patients attest when they check in for their appointment, they're validating that information that is accurate. So the assumption, which is never good to assume, but the assumption is our analysis should be within some standard deviation of accuracy because it's being pulled directly from the medical record. Now, if you want to speak to OpenAI or something broader, I'll have to defer that to those experts on what we'll see over time. It's kind of exciting. It's kind of nerve-wracking to understand what will a year look from now, 2 years look from now. Gosh, when we started in January, it didn't feel like it was moving as fast, and now we're in May. So imagine the next 5 years or the next decade. I can't speak to that intelligently, so I'm going to leave it to others. But I will say, with us confined in the medical record, that's part of the work that we do. And we're relying upon information there and attestations from our patients to ensure that that's correct.
Okay, so a last question on that. You kind of answered the way I wanted to end this, which is what do we look for in the future? But you're talking about medical records. There are, I don't know, you probably know this stat better than I do, but 40% of people in our country do not see a doctor on a regular basis, go to the emergency room if something terrible happens to them, or if they're, if they have a hospital anywhere near them. I don't know what they do in rural areas where you've got to drive 50, 60 miles to a hospital. Those people don't have any records for you to check with the
Yeah.
AI. But they're the ones we have to find a way to serve. How do you
Yes.
put this together so it isn't just you and I with the college education and we know we have to go to the doctor every year or for this or that or the other thing, and all those other people who just don't go, don't see. They're
Yeah.
the medical profession is essentially blind to these people.
Yeah. Yeah. As I shared with you earlier in the conversation, I'm also a mammographer. So breast cancer awareness is very important to me and to just overall this country. There's a lot of women who die from breast cancer.
Yes.
And I remember days where I would get on a mobile mammography unit and travel to rural areas to do mammograms all day long for the underserved population. It's still a large issue. I know it's something we continuously talk about. We have strategies around rural health and how we can fold them into the bigger picture because there are a lot of underserved patients. Now, what is the fix? I can't answer that today, but I do know that's something that our team is top of mind for our organization and our team, and something we're continuously looking at. Like, how can we better fold those patients in, outreach, serve them? Because it is for a large country, we do have a big gap to fill.
All right, Raquel, I think you've said it all and extremely well, as much as you can say today. And
Thank
tomorrow
you.
we'll come back and talk to you again, as it were. Thank you
Yeah,
very much for doing the podcast.
absolutely. Thank you so much for having me. Great topic. We're excited to see what's to come, but more so excited to see how best we can just help the lives of our patients, provide quality care, and use the tools responsibly.
Dr. Racquel Moore is Vice President of EHR Strategy, Governance, and Special Projects at Optum. Dr. Moore leads enterprise AI and digital strategy across a large, multi-platform healthcare network. She has over 20 years of experience spanning clinical care, operations, and health technology. I'll add more on Racquel in the show notes on my pod page. So, let's move on to episode 46. You're going to meet a fifth-year medical student who's studying in Prague, that's the capital of the Czech Republic, where we've done a number of interviews over the years. Like all European countries, it has a universal healthcare system. Czechs pay high taxes, but never have to worry about paying high medical bills as Americans frequently do. The student, his name is Alfir Ladipov, has one more year to graduation. He plans to go into radiology after he does his hospital residency requirement. With so many medical breakthroughs in recent years, and quite a few of them by Czechs, and of course AI, how much has changed in his courses? Well, for one thing, he's totally comfortable with AI, which for his generation isn't an add-on, but just a normal part of student life. I think you'll really enjoy meeting Alfir. Episode 46 will drop on the third Tuesday of July. As you know, I schedule one new podcast episode a month, and if you enjoy the podcast, please follow us or subscribe and share. The video version's on YouTube, audio on Apple, and on all the other major platforms, including my host platform, the Podbeam website and app. Show notes and links on my website, stephanieshelton.com/conversations. You take good care of yourself and all those you love, and I'll see you next time. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.